Welcome to the MRCS Bites session on parathyroid glands. Today, we'll dive into this topic and explore the common questions tested during the MRCS Part B exam. For more information and full course, please visit mrcsbites.com. What are the parathyroid glands? The parathyroid glands are pinkish, brown glands, usually found on the posterior aspect of the thyroid gland. In 90% of individuals, there are 2 on each side, but this varies from 2 to 6. Each weighs about 50 milligrams and measures 6 by 3 by 2 millimeters. How do they develop? The superior parathyroid glands are fourth branchial pouch endodermal derivatives, whereas the inferior parathyroids arise from the third branchial pouch, also endodermal derivatives. The thymus gland is also a third branchial pouch derivative. Therefore, the inferior parathyroid glands may get dragged down with the thymus into the mediastinum, making the position of the inferior parathyroid glands highly variable. The superior glands are more constant in position. What is their blood supply? All 4 parathyroid glands are usually supplied by the inferior thyroid artery. A consequence of this is that the inferior thyroid artery should always be preserved during a total thyroidectomy to prevent ischemia of the parathyroid glands, which would render the patient hypocalcemic, necessitating lifelong calcium supplementation. What is their function? The parathyroid glands secrete parathyroid hormone from chief or principal cells. Parathyroid hormone plays an essential role in calcium homeostasis. Calcitonin, on the other hand, is secreted by the parafollicular cells, also known as C cells or clear cells, of the thyroid gland. What does a general surgeon need to know about the parathyroids? The parathyroids can produce too much, hyperparathyroidism, or too little parathyroid hormone, hypoparathyroidism. Hypoparathyroidism usually follows thyroid or parathyroid surgery. Higher parathyroidism can be primary, secondary, or tertiary. Primary hyperparathyroidism usually results from a parathyroid adenoma, around 90% cases. A benign tumor of usually one, but sometimes more than one, parathyroid gland that leads to the overproduction of parathyroid hormone and hypercalcemia. Treatment consists of neck exploration and parathyroidectomy. Care must be taken to avoid damaging the recurrent laryngeal nerves. Exposure of the thymus through a midline sternotomy may rarely be necessary given the liability of the inferior parathyroid glands to end up in unusual positions. Less commonly, primary hyperparathyroidism results from multiple adenomas. 4% cases of primary hyperparathyroidism. Bilateral hyperplasia of the parathyroid glands, 5% cases. Or rarely a parathyroid carcinoma, 1% cases. In the case of bilateral hyperplasia, always think about multiple endocrine neoplasia. Secondary hyperparathyroidism is usually seen in the setting of chronic renal failure or other causes of vitamin D deficiency, e.g. osteomalacia, malabsorption, where the levels of parathyroid hormone rise in response to a low calcium. Remember that the kidney activates vitamin D. Treatment options include subtotal parathyroidectomy, 3.5 gland removal, or total parathyroidectomy, 4 gland removal, with autotransplantation of parathyroid tissue in the latter case. Tertiary hyperparathyroidism is commonly seen in the setting of renal failure and renal transplant patients and results when the parathyroid glands become autonomously functioning. What imaging modalities can be helpful in localizing parathyroid adenomas preoperatively? Ultrasound scan, USS. Sestamibi isotope scanning. Pre-op localization. Nowadays enables minimal access surgery to be carried out. For more MRCS Part B resources, please visit mrcsbites.com.